Good morning, everyone. Today, I would like to represent Medicine 3 and present about a patient, Hump. Presenting Mrs. X, a 23-year-old primary gravida with 27 plus 3 weeks of gestational age, has presented to us in the month of May this year with the chief complaints of abdominal distension for the past 8 days and dyspnea on exertion, which has worsened for the past 2 days associated with orthopnea. Also, she gave a history of associated complaints of vulval edema and the bilateral pedal edema for the past 2 days. However, there was no history of any fever or vomiting. There was no past history of any jaundice. There was no history of any blood in the stools. There was no history of abdominal pain, hematemesis, or melena. There was no history of any skin rash, joint pain, or oral ulcers in the past. So there was no history of any altered sensorium or tremors or ataxia. Coming to her past history, she had a history of recurrent episodes of blood in the vomitus since childhood, and correct details of the underlying procedure was not given, but the parents told that she had some endoscopical procedure done for the same at 12 years of age. However, she was asymptomatic till her current pregnancy. But in the month of Jan in 2024, when during her first antenatal checkup, she was found to have an anemia with a hemoglobin of 5, and she was transfused with 2 pints of blood locally on 13th of the month. Post transfusion, she was normal for almost 15 days. Again, when she went to other hospital for antenatal checkup, she was found to have a pancytopenia with a HB of 7.2 and WBC of 1400, platelets of 23,000. And over that time, she was also clinically found to have a massive splenomegaly. So an ultrasound abdomen was done to confirm the splenomegaly. And after that, a portal vein Doppler was done in an outside hospital, which has shown a portal vein which was thinned out, and multiple portal cavernopathy with the multiple splenorenal collaterals were present. So a diagnosis of portal vein thrombosis was suspected at that point of time in Jan. However, she was asymptomatic at that point of time, and she didn't follow for 1 month. Later, she visited CMC hepatology for further evaluation and management. And in CMC hepatology, because she was already in third trimester, she underwent further evaluation, and the portal vein thrombosis diagnosis was confirmed, and she was started on prophylactic propranolol for the same. Coming to her obstetric history, this is a G1, which is a present pregnancy, and her menstrual histories, her LMP is September 23rd last year, and her current EDD is 29th of June. Personal history, there was no addictions. She consumes mixed diet. And family histories, there was no history of similar presentation in any family members in the mother. Also, coming to her birth history, no details were known about her mode of delivery or umbilical catheterization, because currently only father was there at the time of presentation. Examination, she was febrile she was conscious, oriented to time, place, and person. She was febrile. Vitals was she had a BP of 90/60 and a pulse rate of 78 with a respiratory rate of 18 at the time of presentation in the OPD. There was no pallor, icterus, cyanosis, clubbing, or lymphadenopathy. However, she was having bilateral pitting pedal edema till up to the knee level. Abdominal examination wise, gross ascetics was present, shifting nullness was present at that point of time. Genital examination, she was also having a vulval edema. However, her respiratory and CVS examination was normal. So the working diagnosis with a clinical history of recurrent blood in the vomitus since childhood, followed by bilateral pedal edema and abdominal distension with a massive splenomegaly, and with already a ultrasound diagnosed portal vein thrombosis. Working diagnosis at the time of presentation was portal hypertension, mostly due to extrahepatic portal vein obstruction. Further evaluation was done, and she was found to have a pancytopenia with a HB of 9.5, total counts of 1600 with the neutrophils of 59%, and a platelet of only 45,000. However, she was also found to have a deranged coagulation parameters with a PT, APTT elevated, and also abnormal LFT. Because she had a ascites on clinical examination, ascitic fluid analysis was done, which was more of a transidative. Her ultrasound abdomen, repeat ultrasound abdomen was done, which again confirmed the presence of a portal vein thrombosis, showing confirming the diagnosis of extrahepatic portal vein obstruction. So our questions at this point of time was, she is presented with a third trimester pregnancy. So what are the challenges in managing extrahepatic portal vein obstruction in a pregnant patient? How to manage that patient? What is the most common presentation? and how is the pregnancy outcome in such patients. So we went ahead and looked into the literature review. This is a retrospective study which is published from our own institution, from the Department of Family Medicine and other departments. But just a brief introduction about extrahepatic portal vein obstruction. As we can see, both the splenic vein and the superior mesenteric vein join to form the portal vein. If there is any thrombosis at this junction, that is predisposing to the extrahepatic portal vein obstruction. There are multiple predisposing factors for the contributing of the same. Inherited disorder like prothrombin gene mutation, factor V lead-in mutation, protein, and acquired thrombophilia can also contribute to this. Other systemic risk factors which can contribute to this include the autoimmune disorders or an underlying malignancy, which includes cholangiocarcinoma or underlying myelodysplastic carcinoma. How does pregnancy worsen the extrahepatic portal vein obstruction is because of the physiological effect of pregnancy, where you can see an increase, 50% increase in the plasma volume and the stroke volume. This will cause an associated with the increased intra-abdominal pressure in the second and the third trimesters. All these factors lead to the increase in the intravenous pressure, causing an increased blood flow and pressure in the collaterals. This causes an increased risk of varicose bleed and will further cause the worsen the portal hypertension in these patients. Coming to the results of the study which was published from our own institution, they took up 28 patients from 2011 to 2019 who were presented with extrahepatic portal vein obstruction, where we can see most of them presented both in primigravida and multigravida, but the average age of the patient was 24.2 years. And the index presentation, most of them presented with a history of a varicose bleed. Like in our patient also, she had a history of a bleed during her childhood itself. And almost most of the patients presented prior to the pregnancy. So the antenatal diagnosis was confirmed already for all the patients. And the treatment modality in most of the patients was varying according to the clinical manifestations, how they produce. Different other studies we looked at, and all these studies confirmed that most of the pregnancies presenting with an extrahepatic portal obstruction, the main outcome which is favoring a native outcome is all of them would have a spontaneous abortion, which is shown as in these studies. Also, all of them will have a thrombocytopenia. But the maternal mortality is very much, even though patients had an extrahepatic portal vein obstruction, but the maternal mortality is very less in such kind of patients. Coming to our results in our institution, the indications for the LSCS in such patients who presented in second and third trimester, the most common indication was a patient who are having an accompanying severe preeclampsia or a chorioamnitis with ARDS, and the previous LSS who were not willing for a vaginal back delivery. And the indications for the blood transfusion, whenever we're planning for a termination of the pregnancy or a pre-delivery and postpartum hemorrhage, and very pre-operative deranged bleeding parameters are the most common indications for the blood transfusion. Coming to our patient, what did we do? When she first time presented to us with ascites, she was already on propranolol beta blocker, which was started from HIPAC. Because of her ascites, we gave her a symptomatic relief by starting her on IV diuretics, and we also did a therapeutic ascitic fluid tapping when she first presented to us. After that, she has clinically become better, and she was all right for a month. But after a month later, she again presented with the same complaints of bilateral pedal edema, abdominal distension, and breathing difficulty. So again, she was found to have a massive ascites, and then we had to do a therapeutic tap by removing only 1 liter, and we gave her an IV diuretics. She was also continued on the beta blockers at the same time. But clinically, she was not improving better, and ascetics kept on increasing. So we had an MDT with the OMC hepatology and the OG team, and we have decided to terminate the pregnancy at 31 plus 3 weeks of gestation. We did an elective LSCS under GA, and a girl baby was born with on 20th with 1.5 kg weight, and she was immediately shifted to nursery for further management. So the learning points in this patient is patients' normal physiological changes of pregnancy can worsen the portal hypertension. However, the maternal mortality rate is very much less, and the antenatal management should always be by a multidisciplinary approach in a tertiary care center. Non-selective beta blockers like propranolol are almost safe in antenatal and lactating period.
Thank you, Bobby. So what is the usual history that you get in the perinatal period? of patients who later on present like this, no, with extrahepatic portal vein obstruction?
The usual history that we get is a spontaneous bleeding, bleeding gums or vaginal PV bleeding.
No, when this patient had been a neonate, what is some important history?
The important history is there an umbilical vein sepsis or a thrombosis?
What is the history they'll have?
That stump won't be healed.
They may have purulent, foul-smelling discharge from the umbilical stump. There may be a delay in it falling off. There may be, cellulitis around that region. So that is a very important history. Since this patient has presented from the age of 12, no?
Yes,
so
ma'am.
something like that in the neonatal period
was could be the etiology of this patient development.
Yeah, I mean, what was the SAG for this patient?
SAG was a low SAG, normal high protein. Okay, just forgot.
Reason I'm asking is because you said that it was a transudate, no?
Yes.
So when you have ascites, we don't talk in terms of transudate and exudate. It's in terms of whether there's portal hypertension or not.
Yes.
Okay. So for her, you would expect a high SAG.
Was a high SAG high protein, normal protein.
So it was a high SAG, low protein ascites. Okay. Anybody has any questions?
How do you explain ascites in this patient?
So increased pressure on the collateral circulation because of
HPVO. It's a classical presentation.
classical presentation would be a varicose bleed.
So when you look at portal hypertension, this patient has portal hypertension. Portal hypertension is you're classifying as pre-hepatic, hepatic, and post-hepatic. Very classical about pre-hepatic is they don't have ascites. I mean, they have portal hypertension, but they don't have ascites. Very classical. All EHPVs, they have a massive splenomegaly, varicose, they bleed, and the bleed is very classical. They bleed without loss of sensory because hepatic function is very well preserved. Hepatic invariably with varicose bleed, with a compromised hepatic function, they go into encephalopathy. So if you have a patient with a massive bleed, with a very preserved sensorium, and if you are considering that as a part of a portal hypertension, it is most likely pre-hepatic. So extrahepatic portal vein thrombosis have two characteristics. One, they don't have ascites. Two, they have a preserved hepatic function. There is no encephalopathy. The only other conditions when you have that is in hepatic fibrosis, NCPF, non-portal fibrosis. So in that, because hepatocytes are normal, so they don't go into encephalopathy. So encephalopathy is a marker of understanding where the lesion is. So if it is affecting the hepatocytes, if it's a post-necrotic cirrhosis, then invariably they have a poor hepatic functions. There are more likely chances they're going to hepatic encephalopathy, and bleed is one of the precipitating factors. So this is what we classically tell is you have a massive hematemesis with a preserved sensorium. The location and anatomical localization is pre-hepatic because you're talking about a preserved hepatic function. So how do you explain ascites in this patient if it is a pure extrahepatic portal vein thrombosis?
Because of the increased physiological changes in the pregnancy, which has caused an increased plasma volume and the increased intra-abdominal pressure causing
Are we saying that EHPVO in pregnancy presents differently than EHPVO apart from pregnancy? So of all the reviews that you did in EHPVO, all of them have ascites?
no, sir. All of them chiefly presented. Main complaint again was a varicose bleed. Yes.
No ascites.
Yes, sir.
So
This patient had an ascites.
So we looked into other causes for. So this patient has a definite portal vein thrombosis.
Yes, sir. Yes, sir.
Has got definitely no hepatic function involvement. Liver functions are absolutely
normal. Liver functions are currently normal, sir. Initially, she had an abnormal LFT. prior to that, at the time of diagnosis also, her LFT was normal in the month of February when she got admitted in the hepat. Then she developed an abnormal LFT. She had she had a pancytopenia and then deranged coagulation parameters with an abnormal LFT. Currently, after surgery, again they are recovering and they become better.
So biosynthetic functions was normal.
Yes.
Albumin,
No.
Yes.
No.
Albumin was
Not- no.
Because if there is a imaging showed liver,
imaging showed absent portal vein flow and thrombosis of the
liver.
liver also showed a cirrhotic changes, sir. Shankar.
So, I mean, this is a clinical thinking. That's what I'm trying to say is, if you have evidence of portal hypertension, if you have done a scopic analysis, very clear that there's portal hypertension. Now you have to say, where is the lesion? Where is the anatomical localization? Is it pre-hepatic? Is it hepatic? Is it post-hepatic? So the clinically, the way you differentiate is what I just said. So if the patient has ascites, it cannot be a pure EHP view because pure EHP view does not have ascites for some reasons. We don't know that because pressures are high in the portal system, but they don't have ascites. That's what we observe. Right? And so if this patient has ascites, then you are not able to explain anything with an EHP view. That means you have to think of anything additional to it. There could be a liver cirrhosis with decompensation ascites, and the portal vein thrombosis could be secondary to that. That may be the other way to look at it, right? And not say that this is a pure EHP view.
Yes.
EHP view is a very different entity where it is only EHP view. But you can have portal vein thrombus because secondary to liver cirrhosis, and whenever you have a portal vein thrombosis in a patient with liver cirrhosis, you always think of a HCC because HCC is the one which will predispose to a prothrombotic state and a portal vein thrombosis. So if you're using the word EHP view, then you should be very sure that there's no other pathology there. So it's just a clinical thinking. But if you're saying that the imaging showed there was cirrhosis, albumin biosynthetic functions are affected, then it's so what are you labeling this patient as? Liver cirrhosis with portal vein thrombosis, and the word EHPAVU has to be reserved for a patient who has only portal vein thrombosis, portal hypertension secondary to that with no liver involvement. If you have a liver involvement, then you have to interpret portal vein thrombus in a different light. Is it something secondary to the portal hypertension, secondary to the liver cirrhosis? So those are some of the clinical thinking that you do in this patient. So this patient did have some features of cirrhosis
Yes.
and some normal liver function which was there. So this patient is also high risk for surgeries because you have a liver dysfunction. EHPVO is safe, liver is reserved, you just have to manage it. But taking up patients with liver cirrhosis with the compromised hepatic functions at a high risk for surgeries because of the liver dysfunctions post-op, they may develop complications which you have to deal with.
Thank you, Bobby. The next is Shan.